So it gives me great pleasure to introduce our first speaker, who truly is a master clinician without a doubt, and really does not need an introduction per se. I would say that, but with regard to our format, I will certainly spend some time to introduce her formally. Professor Malavez is a specialist in maxillofacial surgery and honorary professor at the Faculty of Medicine, the University of Leuven in Belgium, teaching the management of edentulous patients and implant technologies, including bone grafting and zygoma implant protocols over many years. She acts as a clinical chief consultant at the Department of Maxillofacial Surgery and Dentistry at the Children's Hospital of Brussels, treating congenital maxillofacial deformities. She also works as a consultant in implant-based therapy at the Hospital St. Jean in Brussels, and is a team member at the Cleft Palate Center at the Children's Hospital of Brussels. She is a member of the EAO and the Royal Belgian Society of Maxillofacial Surgery, lectures extensively, both nationally and internationally, and is well published in implant surgery. So who better to begin the presentations of, again, the question being the clinical case from which I learned the most. Without further ado, I give you Dr. Professor and wonderful clinician and wonderful human being, master clinician, Professor Malavez.
I'm glad to see you. No, not to see you, but I'm glad to be with you and to participate to this first webinar about zygomatic implant. I was invited by Carlos Aparicio, I know, for a very long time. Do you see my presentation?
Yes, we see it perfectly and we hear you perfectly. Yes.
You see me perfectly, so I can start. And the case from which I learned most, can I close that because, no, I don't know. No. So, the case from which I learned most, yes. Experience is simply the name we give our mistakes, and I did choose this case because it was the first case that was performed with zygoma implants. In 1997, this patient, she was 62 years old, quite good looking. She had been treated by a plastic surgeon who performed a facelift, but he could not do anything for the lower third of the face, as you see. In 1995, I performed level 1 osteotomy with calvarial bone grafting and a delayed placement of implant. In 1997, after 2 years, all the implants were lost. They had been integrated, but they were lost, as well as bone graft, and also as well as bone graft. And she looked like that. It's not her case, but at this moment in 1997, we were not doing the CT scan to appreciate our cases. In 1997, January, I was invited by Pierre Bernmark to come to a first course on zygoma implants in Göteborg. That was in May 1997. And then September 1997, Pierre Bernmark, together with me, he performed a hip graft with 3 implants and 2 Z fixture. This was an implant for preceding the treatment that remained integrated. So that she had 3 implants, bone graft and 2 zygoma implants. In 2000, she did lose the bone graft with the 3 implants, but the 2 Z implants remained very stable. What could I do then? I placed 5 extra oral implants, you know, these very small ones, 4 millimeter diameter with a collar. They integrated. She got a fixed prosthesis, screw it on them, but after 1 year, she did lose the implants, except the zygomatic ones. She also showed repetitive sinusitis during these years. I decided to stop these treatments, and with the prosthodontist, we connected the 2 Z implants with a customized bar and attachments. From 2000 to 2020, we saw her every 3 months. We cleaned the prosthesis, the upper bar, the lower bar. The 4 additional implants have been placed in 1990 in the lower jaw. She had no hygiene. She broke the attachments as well as the screws of the abutments. The prosthodontist added some soft tissue, some soft liner in the prosthesis, and the patient learned to limit the amount of glue. Today she is 87. She comes in a wheelchair and she loves to go to the restaurant. What did I learn? I learned from sinusitis, I learned from bruxism, from hygiene, and from soft tissue dehiscences. And it's almost the thing that we have the problem that we can have when we place zygoma implant. So first, sinusitis. Sinusitis, I did a study in this time, and I found in the paper, I read 0% to 32% of sinusitis. We had in our group 5% sinusitis. How can we avoid that? First, we have to have a very good pre-surgical planning in 2D and 3D, including the virtual positioning of the implants and the total maxillary sinus. And for me, that is mandatory. You have to have a very good ventilation of the sinus, even if you are extra sinusal. You have to remain, second, we should remain as much as possible extra sinusal, not extra maxillary, but be aware of the possible sinus reactions. Since 2009, I only performed quad zygomas, and on 70 cases, I just got 2 sinusitis. But if you look at this case, very recent, in October 2019, the right sinus, and the patient had a myototomy, and there you see it in February, after the placement of implant, you see that there is the augmentation of the Schneiderian membrane, and you have the same on the left sinus that was very open, and here it's still open, but the sinus membrane did augment, so that we always have a sinus reaction. This patient came after 15 years because she broke a tooth of the prosthesis there, and I had never seen her for 15 years. She is now 75, no complaints, no fistula, no pulses, no pull, but sinuses show shadow. What does that mean? It has been explained and it has been described by Botto in a paper about sinus reaction and also by Davo. And by Davo you can read it, it's very interesting. Bruxism. How do you know that a totally edentulous patient is a bruxer? How do you know it? This is my patient. You see, on the lower jaw, you see that she bites on the upper jaw. She has a spasmodic movement of the muscles to maintain in the past a movable prosthesis of the upper jaw. And I sent her to a therapist, and she didn't change anything. And you look at the lower prosthesis, it's the same since 1995. Perhaps you see that it's a little bit worn, but not so much. So when it is too late and the patient has lost implant, how to avoid it? Because we don't know how to treat this patient who have these problems, we systematically give all our patients a night guard made of soft silicone. And we analyze as we can the occlusion. Occlusion is changing in the edentulous patient with, as well as with standard implants or zygomatic ones. This patient, my patient, she never could correct the spasmodic movement she had when she had a very unstable removable prosthesis. She kept it with the implants, and I think is the reason why she did lose so many times implants. The third thing is hygiene. Excellent hygiene is mandatory, really mandatory. How to maintain? First, with a correct prosthetic design, the acrylic, or what it should be, has to be polished. It has to be round. It has to be to help the patient to clean it. That is unacceptable, and that also because the foot will remain there. Patient has to use little brushes to insert around the emergence points of the implant, and if they cannot, I strongly recommend, some people are against, but I strongly recommend the use of the water pick. They apply horizontally from buccal to palatal. If they can't use the little brushes, they stop brushing, and then they do not clean their prosthesis. So the water pick, even if it is not the best solution for me, is something they have to use. This is my patient. You see on the upper jaw. She came she came 2 months ago because we have no lockdown. She came 2 months ago, and you see that it's not very clean, and there is another problem there. And the lower jaw, the lower bar, I did clean it before the pictures, but you see that there is inflammation there, and then there is a loss of bone. And then it's another patient, it's a Swiss patient. You can see also that this patient, they do not clean as we ask them to do. In conclusion, hygiene is a very difficult parameter to supervise, but we have to give the patient the opportunity to do it well, and the follow-up is mandatory. We have to see this patient at least twice a year. Soft tissue dehiscences. This was sent to me by someone. It was sent to me. That's something that can happen also. That's one of my patients. No good hygiene, and it was a patient of Ruben Davo, and he showed that you can correct the implant there. Perhaps we speak about that, I don't know. How to avoid these dehiscences? Do the incision palatally to keep as much as possible attached fibrous tissue around the implant. You can also do some soft tissue graft, as Carlos Aparicio did publish. And in this case, I'm quite sure that the incision was done there because all this fibrous tissue is palatal now, and it should be not there, but it should be there. Second, keep as much bone as possible buccally like that here, to have a possible attachment of the soft tissues. And it's the same patient, and we see that we have a very good, nice situation 18 months after the surgery, and it's now a case that is 8 years old case. The protocol with a sinus lift window, that's the protocol one of the preferred. Keeping bone in place is derived from a protocol proposed by Jane Shaw. I use it in all the quad cases. Bone comes back, and you see it here. There is some change in the anatomy of the sinus of the zygoma bone, but bone comes back in between the two implants without any other material. You can add, if you like, and if you feel more comfortable, buccal fat pad, published in 2018 by Gwenal, a bone or bone substitutes, PRP or PRF, or artificial membrane. As far as I know, there are very few publications giving you the scientific background and long-term results of these additional procedures, so that you can do it. It will not jeopardize the result, but I am not sure it is necessary. The best for me, of course, is to try to avoid adherencies. Keep the bone as much fibrous tissue as possible, and keep some bone here, some buccal bone in front of the implant in any case, and it can be done in any case. So now, that's my patient. She was 65 and she had bone graft with a titanium membrane. She was 82 and she hesitated during 1 year before doing it. She participated to a study about noble gas zygomatic implant, and she had 2 sinus lifts. They were infected, and she's a wonderful patient, and she also hesitated very long time before doing it. And this patient, you see her before the treatment, you see her 1 year after the treatment, and there you see her today after 9 years. And of course, there are men. I do not only treat women, happily, I treat men also. This one came from Russia. This one came from Belgium also. So, in conclusion, I would like to say that the easiest solution is always the best. Do not trust short implants in the anterior maxilla for long-term survival. Quadzygoma is much more difficult in terms of surgery as well as prosthetic reconstruction. But it is evident for me that in severe atrophies, quadzygoma is the best for the patients. Quadzygoma will dramatically improve their quality of life. And I thank you for your kind attention.
Thank you, Dr. Malavez. An outstanding case presentation. Without a doubt, the pearls that you left us are just, wow. what can I say? I mean, in terms of addressing sinusitis and soft tissue dehiscences and bruxism and hygiene issues in general, I mean, these are issues that we all face. And over the years, with your vast experience, you certainly are the best individual, at least in my humble opinion, to be able to comment on these various items. And most impressively is to show the evolution of this particular case from start to finish. So thank you so much for an outstanding presentation. Thank you.